So this is a 15-year-old boy presented with new onset seizures and presented to our ED where a CT head was performed, which confirmed that there was no hemorrhage. And so but it did demonstrate this unruptured left temporal arteriovenous malformation on the CT angiography that you can see here, right? So all of this was done in his initial ED evaluation. And so what I know right off the bat is that this is not a ruptured lesion, and that we are now, in my mind, I'm going down that unruptured treatment pathway, which certainly is something that buys you a little bit of time to more strategically plan management. Now, after recovering from his first seizure, he was neurologically intact. He was started on anti-epileptics, and it controlled his seizures very well. He had really no other breakthrough activity. So, one thing we didn't talk about is there definitely is some literature that supports the idea that new onset seizures may portend in the coming 6 months for an increased risk of rupture. But, given how heterogeneous this pathology is, that's, again, just a trend and not an absolute. So, these are some videos I have on each of the 3 projections. I think they actually go faster than I would like, but I'll start them in a second. But on the bottom, hopefully you can appreciate in axial, coronal, and sagittal projections that there's a nidus in each of these projections that is focused in the posterior aspect of that left temporal lobe, right? And we'll talk about that location in a second. So sorry, I'm going to try to see if I can stop these. So a little faster than I would like, but in general, hopefully these static images give you an idea of the exact location. So size-wise, certainly, less than 3 centimeters. It's near the cortical surface. Other considerations in terms of eloquence is left temporal lobe, where we know that certainly there's a high possibility of language and some visual fiber projections to be mapped subcortically. And then we also did a stealth study in preparation for any OR planning, where you can start to see some of the draining vein, again, quite superficial. The study didn't really demonstrate any deep venous drainage, but again, you can see here the nidus, right? So preliminarily gives you a good picture, right? So this patient now is an ED, and how do you counsel the family in seeing them? And in general, question 1 is obviously, what is the grade of the AVM? So we talked about the size being less than 3, so he gets 1 for that. There's no clear evidence of deep venous drainage, so maybe we'll give it a 0 for that now. And it may be eloquent, so we'll err on the side of being conservative, so we'll give it a 1 for that. So preliminarily, let's say it's a grade 2 arteriovenous malformation. And then the question is, what are the next steps? And as we talked about, we really need to get a better assessment of are there any high-risk features that may modify my risk estimation? And so the next step, I think we can agree on, is angiography. So sorry, these are going faster than I'd like, but this is a left carotid injection, which is showing the left middle cerebral artery feeding this temporal AVM. And then on the lateral projections, you can start to see that there's this one larger draining vein, and there's actually a second draining vein that comes anteriorly. So there's 2 superficial draining veins. And one of these draining veins you actually can see quite well here. This is the smaller of the 2 that goes along the cortex and empties into that superior sagittal sinus. So the other thing we're looking at is high-risk features. And clearly, we didn't appreciate any feeding artery aneurysms. We didn't appreciate any nidal aneurysms on the arterial side, and there were no venous aneurysms. And in terms of the venous outflow, there was no evidence of outflow venous obstruction, right? So in terms of high-risk features, fortunately, there was nothing here that I would estimate as falling into that category. And these are clearly very important things for us to know. So, this gets back then to this actuarial table. And so if you say that the child is 15 and you're looking at no high risk features. So maybe we say it's a 2% rupture risk. So a lifetime risk of 70% would be a reasonable estimate for a discussion point for a lifetime risk for a 15-year-old child. Now, if you apply our 105 minus 15 formula, that gets you something higher, right? And we talked about how that tends to overestimate things a little bit. So that estimates a little bit closer to that 4% risk of rupture. And so you can already see that that formula is a great starting point, but things like this actuarial table that give you some options is probably a little bit more nuanced. So in any case, I think whether you say it's 70% or 90%, I think we can agree for a 15-year-old child that risk is really very, very high. So the next questions that we have to consider is, are we going to treat or not, as question one. And based on that risk for a 15-year-old, I think in general, most of us would agree that treatment, if it can be done safely, would be the more prudent strategy. And then if we decide on treatment, then we have to talk about surgery, stereotactic surgery, or embolization. And then, are there any additional studies? You remember we talked about some of these advanced studies. And in this case, although I don't have the pictures here, we did do a functional MRI to confirm, and I'll just go back to this left temporal AVM. You can see it sitting on that posterior aspect of the superior temporal gyrus. So it's most likely behind language centers, but we did do a functional MRI to confirm that language, in fact, was anterior, and that we did diffusion tensor imaging to confirm that the visual fibers, in fact, were just deep to this particular lesion. So it certainly looked resectable, but the conversations we had with the family were that, if we were to embark, for example, on surgery, we have to potentially assume that there may be some partial superior quadrant field cut on the right. And then the other treatment options of radiosurgery, this is certainly a lesion that could be embolized, just looking at the size and location of it. But embolization, of course, carries a 2-year latency. And in children, I think general philosophy is to minimize radiation exposure and maximize or utilize surgery when ideal. So radiosurgery didn't seem like a great option for us. And then potentially embolization, the angio architecture of this with a single large inflow certainly was amenable to embolization. And so these are some of the projections before embolization. And let me see if I can stop this here. And you can see that there's a single large arterial inflow going into this nidus. So we did go ahead and embolize this. This is the larger of the two venous outflows. This is the smaller of them. And so this is a slightly lower risk lesion because it has two venous outflows. And the way we approached this is we decided we were going to do preoperative embolization followed by microsurgery. And so, at our institution, we have a hybrid room where we're able to remove these AVMs, and then while the patient is on the table, obtain a postoperative angiogram at the same time. And so that's exactly what we went ahead and did. So after embolization, you can hopefully appreciate that this particular feeder is now closed. So you're seeing a much slower AVM, and you're not seeing that second draining vein because most of the demand now is just into this one. And this is a much slower and certainly a little safer lesion to resect. So we went ahead and successfully resected it. And in our biplane suite, you can see one of the projections confirming that the AVM now has been completely removed. And this was the previous location of it. And so this child is 15 years old. And in general, our paradigm has been that around the age of 18, we tend to repeat imaging because there is a meaningful recurrence rate in even cured pediatric patients.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.